Hello everyone. Welcome back to the series of lectures in hepatology. In the previous session, we had learned about autoimmune hepatitis. So in today's session, we'll be learning about the autoimmune diseases of the biliary tree. So let us begin. So before we understand the meaning of autoimmune diseases of the biliary tree, let us understand the meaning of biliary cirrhosis. Okay, so what is this term biliary cirrhosis? So biliary, as the name suggests, basically refers to anything to do with the bile duct. Okay, so it basically refers to the disorders affecting the bile duct. So what happens is that there are certain groups of disorders which affect the bile duct and they cause damage of the bile duct, especially the autoimmune disorders. So when there is damage to the bile duct, over the course of time, there can be cholestasis, and what is the meaning of cholestasis? That basically means that the bile is not getting secreted into the bile duct. So over the course of time, the inflammation that affects the bile duct can cause cholestasis, and the inflammation can progressively involve the liver and cause chronic liver disease. It can cause chronic liver disease. The chronic liver disease that basically occurs secondary to this biliary disorder is what we call as biliary cirrhosis. This is what we call as biliary cirrhosis. Okay. So whenever we talk about cholestasis, this cholestasis or basically the damage to the bile duct and there is impediment to the flow of bile through the bile duct and into the intestine. So this cholestasis can be classified as intrahepatic cholestasis and extrahepatic cholestasis. Intrahepatic means that there is an obstruction within the bile duct. So there is an obstruction to the flow of bile within the bile duct. Right? So this can be because of what? This can be because of maybe a stone, maybe a stricture. Right? This can be because of a stone, this can be because of a stricture, or it can be due to certain autoimmune disorders that we will be looking at. What is extrahepatic cholestasis? So extrahepatic cholestasis basically means that now this is the liver and this is the bile duct which arises from the gallbladder. Now what is here? This is your pancreas. It joins with the pancreatic duct. The cystic duct joins with the pancreatic duct and it basically goes and empties the bile in the intestines. Right? So any disorder which causes compression of the bile duct externally. For example, if there is a tumor which is arising, let us say from the head of the pancreas, so this is going to compress the bile duct externally. Similarly, if there is fibrosis in the retroperitoneum, right? This is your retroperitoneal fibrosis. This is going to compress the bile duct externally. So this is what results in your extrahepatic cholestasis. A lymph node in this region can also compress the bile duct. So what are we studying now? We are studying about the autoimmune disorders of the biliary tract. So we are trying to understand this term biliary cirrhosis. And what is biliary cirrhosis? The chronic liver disease that occurs due to long-standing cholestasis. Long-standing cholestasis occurring due to damage to the biliary tract, most often autoimmune in nature. Okay. The common features for biliary cirrhosis is the evidence of cholestasis, right? So how would you look for evidence of cholestasis? So on the LFT, what are you going to find? On the LFT, you're going to find a raised alkaline phosphatase, right? Because we have learned in our approach to LFT chapter that ALP basically denotes cholestasis. So there is ALP and GGT will be elevated in your liver function test. Apart from that, when you do the ultrasound, you can find evidence of biliary damage. You can find evidence of maybe a biliary dilatation because of obstruction, or you can find evidence of biliary damage. The best investigation to look at the bile duct would be an MRCP, which is an MR, magnetic resonance retrograde cholangiopancreatography, where you can look at the biliary tree more in detail. The second feature would be the evidence of chronic portal inflammation. So as you can see, whenever there is cholestasis, the portal tract is the one which will get affected first. So you can find evidence of chronic portal inflammation. Over the course of time, what happens? this inflammation which is there in the biliary tract spreads over to the liver. So, if this is your biliary tract and this is your liver, initially the inflammation is here, but then later on as the disease progresses, the inflammation will move towards the liver. And then what happens? Because of the damage, the biliary ducts get destroyed. The biliary ducts get destroyed and this results in ductopenia, right? The fourth common feature which is basically present when we talk about biliary cirrhosis is the presence of xanthomas and xanthelasmas. So, why does this feature happen? We know that the bile is basically responsible for a lot of other metabolic functions as well. So, we know that bile is involved in lipid transport. So, when the bile is not transported properly, then you can have accumulation of lipids and hence you can have xanthomas and xanthelasmas. Okay. So, the common feature of biliary cirrhosis of any type, be it autoimmune, and under autoimmune there are two major disorders that we will be studying, which is your primary biliary cirrhosis and your primary sclerosing cholangitis, right? So, all of these have these common features, which is your cholestasis, chronic portal inflammation, ductopenia, xanthoma and xanthelasma. Okay. So, we have understood what exactly is biliary cirrhosis and what are the common features that it shares. Alright, fine. Now, let us look at the first prototype disorder again under your autoimmune disorders of the biliary tract, which is your primary biliary cirrhosis. Okay. The primary biliary cirrhosis is also called as primary biliary cholangitis. Okay. Remember the short form PBC. Primary biliary cirrhosis or primary biliary cholangitis. Okay. So, let us understand some features. So, what is the age group at which this primary biliary cirrhosis presents? Primary biliary cirrhosis basically presents at the age group of around 40 to 50 years. At the age group of around 40 to 50 years. So, what is its gender predominance? The gender predominance is, it is more predominant in females. So, this is a more female predominant disease with a ratio of 9:1. There are a lot of autoimmune disorders which usually have a more female predisposition in the ratio of 9:1. We will be learning this in rheumatology as well. So, the other disorders which have a female predominance of 9:1 includes SLE and it includes multi-system connective tissue disorders. Okay. So, it includes SLE, it includes mixed connective tissue disease, it includes Sjogren's syndrome. Okay. And remember that primary biliary cirrhosis also has a female predisposition. Fine. So, what is the cause? What is the cause? We should always be trying to understand what is the cause. Unfortunately, there has been no cause which has been identified. Due to unknown reasons and sometimes due to unknown triggers, there is development of an autoimmune reaction where the body starts reacting against its own biliary tracts. Okay. So, what do you find on the pathology? So, the very important term that you should be knowing is the chronic non-suppurative destructive cholangitis. Okay. So, what does this mean? This basically means that there is a chronic inflammation that is going on in the biliary tract. So, what does this mean? This means that there is a chronic inflammation which is going on in the biliary tract and this is non-suppurative in nature. This means that the inflammation is not because of any infection. It's not because of any pus formation. There is destruction of the cholangian tract. That means that there is destruction of the bile ducts and there is cholangitis. We know that itis basically means inflammation. So, there is destructive inflammation of the biliary tract, right? And there can be necrosis of the portal tracts. And which bile ducts are most commonly involved? They are the medium and small sized bile ducts. Medium and small sized bile ducts are the ones which are commonly involved. So, primary biliary cirrhosis is basically an autoimmune disorder where it is more common in females of 40 to 50 years of age. Cause is unknown and it mainly involves a medium and the small sized biliary tracts. Okay. So, what is the type of inflammation? It is usually a neutrophilic inflammation, right? So the first stage is that there is inflammation. Okay, the first stage is that there is an autoimmune trigger and there is inflammation, there is diffuse infiltration of neutrophils into the bile duct. Over the course of time, what happens? Over the course of time, the bile ducts get destroyed and there is ductopenia. Then this inflammation basically progresses into the liver. Now we have learned in the basic anatomy of liver as well. Whenever there is some kind of an inflammation or damage to the liver, which cells get activated? The cells which secrete transforming growth factor beta. Which are those cells? They are your stellate cells. They are your stellate cells or cells of Ito. Right? So the stellate cells get activated. When the stellate cells get activated, there is transforming growth factor beta production, and TGF beta basically causes what? It causes fibrosis. It causes fibrosis. Okay? Because it tries to repair. Whenever there is an inflammation, there is destruction, it tries to repair, and a byproduct of this repair process is your fibrosis. So in a chronic long-term span, there is initially destruction, repair, finally leading to fibrosis. Initially, the fibrosis is basically only in the portal area where the bile duct joins, right? So the fibrosis is here in the portal area. Then it progresses such that the fibrosis basically extends from the portal area to the central area as well. And this is what we call as bridging fibrosis. And in the final stage, what happens is that the entire liver gets fibrosed and there is episodes of regeneration, degeneration, and finally there is nodule formation, and the nodular liver that occurs because of that is what we call as cirrhosis. Okay? So this is your basic pathophysiology and your pathological changes which occur in biliary cirrhosis, especially in your primary biliary cirrhosis. Alright? So I hope we are clear till here. We have understood that there is an initial phase of inflammation followed by ductopenia, periportal fibrosis, bridging fibrosis, and then cirrhosis. Now let us understand the clinical features of primary biliary cirrhosis. Okay? So the most prominent symptom is most of the patients remain asymptomatic, and if at all they present, it is a very, very non-specific, and the most prominent symptom is fatigue. So a middle-aged lady basically presenting with unexplained fatigue, you can think of primary biliary cirrhosis. Okay? Apart from that, there can be pruritus. Okay, there can be pruritus. Pruritus is what? Itching. Pruritus is what? It is itching. Okay, and why do you get itching? Because of your cholestasis. So a very characteristic feature of any type of obstructive jaundice and any type of cholestasis is the presence of this extensive itching and pruritus. And the pruritus can be so severe that you can also find scratch marks. Right? So in every patient that you examine for jaundice, please look for scratch marks. If the scratch marks are present, it indicates that this can be a cholestatic or an obstructive jaundice. What is the significance of the pruritus here? If the pruritus is happening before the occurrence of jaundice, it means that this is a portending sign of poor prognosis. They have a worse prognosis. Okay? The next clinical feature is that they can have jaundice. And what type of jaundice do they have? They have an obstructive jaundice. Alright. So this is about your most important clinical features. Now apart from this, on examination, what are the other things that you have to find? Over the course of time, there can be chronic liver disease. So initially you can have some amount of hepatomegaly. Over the course of time, when there is cirrhosis, there will be shrunken liver, so the liver will not be palpable. But there can be stigmata of other signs. Or what is that? That includes splenomegaly, that includes dilated veins. Dilated veins where? In the periumbilical region. In the periumbilical region, that is what we call as what? We call as caput medusae. That is because of your portal hypertension. Okay, there can be ascites. Okay, so these features of portal hypertension can develop. They can have stigmata of chronic liver disease if the PBC has been going on for a long time. Okay. Then in the skin, what will you look for? You will look for jaundice. You will look for jaundice. Most commonly in the sclera, if the jaundice is more severe, you can have yellowish discoloration of the skin as well. You will look for scratch marks. And the most typical, most characteristic feature that you have to remember is that there is a diffuse hyperpigmentation. There is a diffuse hyperpigmentation, and this hyperpigmentation is more prominent in the trunks, Also, what is the other most important feature that you know? We know that the bile is responsible for the transportation of lipids, right? So, if there is a deficiency in the bile, what happens? You can have something called as your chronic long-standing diarrhea. You can have chronic long-standing diarrhea because of your biliary insufficiency. Apart from that, because the lipids are not transported well, including the fat-soluble vitamins will also not be transported. So, you can also have fat-soluble vitamin deficiency. What are the fat-soluble vitamins? They are your A, D, E and K. Right? So, you can have deficiencies of your fat-soluble vitamins A, D, E and K. Chronic vitamin D deficiency, what will happen? The bone will get affected. You can have osteopenia, you can have osteoporosis. You can also have rickets, and hence you will have a very poor bone health, and it predisposes to fractures as well. Then the most important, if the lipids are not getting transported well and not getting absorbed, then there can be external lipid depositions in the form of xanthomas and xanthelasmas. Xanthomas are basically tuberous structures which occur due to lipid deposition. Xanthelasmas are more flat deposition of lipids, especially like around your eyes or in the palms and so on. Okay. So, this is about the varied clinical features which you can find in association with primary biliary cirrhosis. Okay. So, I hope you understood what are all the clinical symptoms and why does it happen. Alright. Now, let us understand what laboratory features you can find in PBC. What are the laboratory features you can find? In your LFT, what will you find? Of course, you can have a TB and DB, which is your total bilirubin and direct bilirubin, that can be elevated. Then your ALP-GGT can be elevated, yes, because this will be a cholestatic pattern of liver injury. AST-ALT may be elevated but in the later stages, but it is predominantly a cholestatic pattern. Then what happens to the serum albumin? Because it is a chronic inflammatory disease, serum albumin will be reduced and there can be hypergamma globulinemia or gamma globulins will be high. Alright. Then you can have something called as your overlap syndrome. What is your overlap syndrome? Since both the disorders, autoimmune hepatitis and primary biliary cirrhosis, are both autoimmune disorders, an overlap syndrome can occur, which is an overlap between your primary biliary cirrhosis and autoimmune hepatitis. Okay. So, in these conditions, the prognosis is much poorer, and in these conditions, your AST-ALT will also be elevated. Okay, so that is your overlap syndrome. The diagnostic test or the test which is used to clinch the diagnosis is the presence of your anti-mitochondrial antibodies. These are also called as your AMA. These are antibodies which are directed against what? Against the pyruvate dehydrogenase system in the mitochondria. Okay. So, when the pyruvate dehydrogenase complex is damaged, then there can be generation of reactive oxygen species. The reactive oxygen species increase and there can be further damage to the liver. About 10% of the individuals can be anti-mitochondrial antibody negative. About 10% of the individuals can be AMA negative, and in those individuals we use SP100 and GP210 as your markers. Okay, fine. Now let us understand the treatment of primary biliary cirrhosis. So the first line treatment is the presence of or the use of ursodeoxycholic acid. Ursodeoxycholic acid. This is used at a dose of 13 to 15 mg/kg per day. Okay, so we give UDCA. But the main function of UDCA is that it decreases the progression of the disease. It decreases the progression of the disease, but it does not affect the recovery, right? So it does not mean that you give UDCA, patient will recover. No, this is a chronic process and it only decreases the progression of the disease. Okay, so there can be many patients who are not responsive to UDCA. So the second line treatment includes treatment with obeticholic acid. Okay, and in very severe cases, there have been trials where they have used rituximab, which is your anti-CD20 antibody, which has been tried, but this is your last resort management. Okay, and if there is no improvement to any of this, then finally you have to do a liver transplant. Finally, you have to do a liver transplant. Now, what about the pruritus, right? So, it's not only the liver, there are a lot of other symptoms with which the patient presents, right? So, pruritus is usually managed with the help of antihistamines. It can be managed with the help of antihistamines. Apart from that, you can also use, for intractable pruritus, you can also use your opioid mu receptor. So we can also use opioid mu receptor agonists such as nalfurafin. Okay. Then patients can also have this fatigue. So for them you have to counsel the patient well and you have to explain that they have to take frequent rest. Okay. Then the third, you can have osteopenia and osteoporosis. So for long-standing cases, you supplement them with calcium and vitamin D and do frequent screening for fractures and severe osteoporosis. Bisphosphonates have been used plus minus, but you start off with calcium and vitamin D supplementation. Okay, fine. So this is about the management of primary biliary cirrhosis. So we have learnt about primary biliary cirrhosis. Now let us move on to primary sclerosing cholangitis, which is your second type of autoimmune disorder of the biliary tract. Now, what is the cause for primary sclerosing cholangitis? Like primary biliary cirrhosis, this is also most of the time the cause is unknown. But you can have some triggers. The triggers can be maybe a virus, maybe OCPUs, but none of it has been proven by far. So these are only theories, right? So what about the pathology? What about the pathology and how is it different from primary biliary cirrhosis? Here, the inflammation that affects the biliary tract affects the complete biliary tree. It affects the complete biliary tree. And not only that, it does not affect only the biliary tract, but it can also spill over and surround the biliary tract, which we call as your pericholangitis. So, the two important histopathological differences to differentiate from primary biliary cirrhosis is that there is inflammation of the complete biliary tree and there can be pericholangitis as. Now, what are the clinical features of primary sclerosing cholangitis? It is very similar to primary biliary cirrhosis, right? So, this is also associated with predominant symptom as fatigue. Okay, you can have fatigue, you can have jaundice, you can have pruritus, right? You can have fatigue, you can have jaundice, you can have pruritus. But here, the pruritus in primary sclerosing cholangitis is not associated with any prognostic factor, right? There we had learned that in primary biliary cirrhosis, we had learned that if the pruritus occurs before the jaundice, it means poor prognosis. But here, it does not mean anything, right? But associated pruritus is present. Then you can have your symptoms of fat malabsorption. You can have your symptoms of fat malabsorption and chronic diarrhea that we had already discussed, similar to primary biliary cirrhosis. You can have your fat soluble vitamin deficiencies. Okay, fine. Now let us understand the lab features. The lab features in the LFT, again this is easy. You will have ALP-GGT high. You can have albumin is low and hypergamma globulinemia. Even in primary sclerosing cholangitis, you can have an overlap syndrome with autoimmune hepatitis. When this disease progresses and if it becomes a chronic liver disease, you can have your coagulopathy where prothrombin will be elevated. Okay, fine. And the most important biopsy feature is that there can be involvement of your complete biliary tract. Complete biliary tract is involved, right? Unlike your primary biliary cirrhosis where only the medium and small sized ducts are involved, here the complete biliary tract is involved. So, in the large duct when it is involved, the inflammation goes like this and the large duct PSC usually gives rise to this kind of an appearance which is called as your onion skin appearance. So, the inflammation happens in concentric circles and there can be final sclerosis or thickening of the biliary tract, and this gives rise to an appearance which is called as your large duct onion skin appearance. So, the large ducts when they are involved, they can have an onion skin pattern. Okay. Now, what are the antibodies? So, there we had learnt about anti-mitochondrial antibodies in primary biliary cirrhosis. In primary sclerosing cholangitis, the antibodies which are seen is that in 65% of the patients you have your P-ANCA positivity. Okay, you have your P-ANCA positivity. Okay, and in some patients you can also have a cardiolipin antibody as well. The other antibody which you can find is your cardiolipin antibody. Okay, another very important thing is that primary sclerosing cholangitis has a strong association with ulcerative colitis. So, every patient of primary sclerosing cholangitis always do a colonoscopy to rule out inflammatory bowel disease, especially ulcerative colitis. Okay, and the most dreaded complication of primary biliary cirrhosis is the development of cholangiocarcinoma. Which is your cancer of the biliary tract. Okay, so this is about the salient features of primary sclerosing cholangitis. So, how do you definitively diagnose? Of course, on the biopsy we know that, but in the ultrasound it is very difficult to find out PSC, and the investigation of choice would be an MRCP, where you find this kind of a beaded appearance of the biliary tract. You can either do an MRCP or an ERCP. MRCP is magnetic resonance cholangiopancreatography and ERCP is your endoscopic retrograde cholangiopancreatography. So, ERCP basically refers to endoscopic technique where through the endoscopy or an upper GI endoscopy, you go into the bile duct and visualize it. MRCP is a non-invasive technique where you do an MRI sequence and you image the biliary tree. And what is this characteristic appearance? This is a beaded appearance of your biliary tract. So, what is the treatment? Unfortunately, unlike primary biliary cirrhosis, the response to UDCA is very poor in primary sclerosing cholangitis, and the final treatment is your liver transplant. Okay, so here the response to UDCA is very poor and the final treatment is your liver transplant. So, this is about your primary sclerosing cholangitis. Now, let us understand the differences between your PBC and your PSC. Okay, so this is just like a revision. So, primary biliary cirrhosis is more common in females, female to male, but primary sclerosing cholangitis is more common in males. Okay, what is the age group in which PBC is more common? This is around the 40 to 50 years age group, right? Primary sclerosing cholangitis also occurs somewhere in the middle age. What are the histopathological differences? Primary biliary cirrhosis involves the middle and small ducts, right? This involves the complete tree. And onion skin appearance is seen where? Onion skin pattern is seen in primary sclerosing cholangitis. What about your antibodies? These are AMA positive, Primary sclerosing cholangitis is your P-ANCA antibody. Association with ulcerative colitis is more with primary sclerosing cholangitis. Risk of cancer. Primary biliary cirrhosis also has a risk of cancer. Here it is hepatocellular carcinoma. In primary sclerosing cholangitis, it is more common a cholangiocarcinoma. Apart from that, you can have colon CA, you can have HCC as well. Which is more responsive to ursodeoxycholic acid? It is your primary biliary cirrhosis, whereas your primary sclerosing cholangitis is not so responsive to UDC. So this brings us to the end of our chapter on autoimmune disorders of the biliary tree. We have learnt about the two most important disorders, your PBC and PSC, and how do you differentiate between both. Thank you.